So my name is Daniela Paolotti. I am from ISI Foundation, and today I will tell you about a Europe-wide online surveillance system that we developed to track flu through self-reported symptoms, and what use you can make of these sort of digital traces left by these online volunteers. We have heard what it takes to build a synthetic population from the talks of Madhav and of Chris Barrett, and from Alex we have heard how data have to be collected in a way that has very present what's the problem. When it comes to studying diseases, unfortunately, the situation looks like that, and this is the familiar picture that all of the scientists involved in public health or in epidemiology know about diseases, that what you see, what you observe through the surveillance means that you have are really only the tip of the iceberg, and that what affects, what impacts a population in terms of a disease burden, it's quite more complicated. Usually what we do in terms of public health surveillance is observing the numbers from these three, let's say, systems: general practitioner visits, hospitalizations, and deaths. And this is true for mainly all the diseases. And unfortunately, it is very hard to tackle what's going on actually among the general population. Even when it comes to a very well-known and very well-studied disease like influenza, knowing how much influenza actually circulates among the population, it's quite a hard task. But hey, we live in the digital age, we have big data, so the digital traces left by people on the internet can help us to look for the truth. So let's see. Well, actually, specifically for influenza, it's something that has been studied quite a lot in the past, let's say 6-7 years. Twitter is the most used let's say, resource to collect data about the circulation of influenza among users, just by really counting how many times people talk about their symptoms online. It's a good proxy to know how much influenza, or let's say influenza-like illness, is circulating among the population. And this has been done with several data sources, not only Twitter, but also, for example, Wikipedia. And if we look at China, even the search query from Baidu in China can work as a very good proxy to estimate how much influenza is circulating among the population. Probably the most famous and one of the first was Google Flu Trends, that would use search engine query data to collect information about, as a proxy, about the circulation of influenza among users. And it has been used for several years as a good surveillance tool, especially in those countries in which the public health institutions or the surveillance system would not work so well. If we think about developing countries, Google Flu Trends was quite a well-established tool. Of course, we know that it has its limitations, and it was not the perfect tool. It had many issues. But it was a good way to measure influenza for quite some time, even though at a certain point people started to believe that this kind of tool was affected by several issues. And one of the paper, even from Alex, was stating the fact that the black box that was under this tool was really one of the main issues that would lead to a reduced trust in this kind of results. But still, it was a tool for understanding what was going on among the general population when the surveillance, let's say the official surveillance, couldn't go there. Besides this, the issues that we are interested in tackling in this context is the fact that big data are great. They provide you with a lot of information, but unfortunately they don't describe who's well, who is not sick. You can have traces of people complaining about their symptoms and about their diagnosis from the doctor related to flu, but when you are really feeling healthy and you're feeling great, probably you don't go around tweeting, oh, today I'm really just great, and it's a kind of information that it's much harder to collect. Moreover, we really don't know exactly what people are speaking about, even if they are talking about symptoms. So there is a low specificity in this kind of tools. So given all these problems, even before the big data era, we wanted to really know what was going on among individuals who wouldn't go and see a doctor when they were sick, maybe with influenza-like illness symptoms. Like all of us would do if you have fever, if you have cough, you probably don't go to the doctor, just stay home and wait for the symptoms to go away. So how do you measure, how do you count the cases of individuals who are not detected by a doctor? And this is something that came up in the collaboration with Alex Vespignani and Vittoria Colizza back in 2008, when during the development of the global epidemic and mobility models that Alex just told you about, when we needed to start collecting data about ILI cases among individuals without having, let's say, high-resolution data from traditional surveillance that is usually at the country level, so it's not at a high resolution enough for this kind of models. So what we did was to build a system that we called InfluenzaNet, and that was really relying on the activity of volunteers, self-selected among the general population, to ask them to self-report their symptoms when they were sick through a website, through let's say a web platform, through which we could collect this kind of information. So starting from two pre-existing systems in the Netherlands and in Portugal that were mostly communication science projects about influenza, we thought that by really piggybacking on these kind of projects, we could collect data from people interested in knowing more about influenza and visiting these online platforms. And so starting from Italy and then going country by country, we built a network of web-based platforms that would use the activity of volunteers, again self-selected, over the internet, that would report their symptoms every week, let's say, during the influenza season. So it was, we thought, a great way, and we still think, a great way to collect very high resolution in time and in space information, and at high specificity, kind of information that would not be detected by traditional surveillance. And I would like to stress the fact that this high resolution is not, cannot be reached by traditional surveillance, and cannot also be reached by big data because of the low specificity that I just mentioned. How does the study design of InfluenzaNet works? We have a, let's say, communication campaign that promotes the platforms in all the countries. The platforms are localized in the language of the country in which the platform is deployed. The volunteers are self-selected themselves. They enroll, they register on the website, and then they become part of a cohort of volunteers who are presented a one-time survey at the beginning of the study, in which we ask them to report, for example, their age, their gender, the postal code where they live, their educational level, their occupation, their household composition, and so on and so forth. So the kind of information that we collect from our volunteers is quite detailed. And then during the influenza season, every week they receive a reminder in which they are invited to enter another survey in which they can report whether they are healthy, or they can select a set of symptoms from a list of respiratory, systemic, and gastrointestinal symptoms, through which we can calculate the syndromes, so clusterize the symptoms in relation to syndromes, and have a very good idea of how many, let's say, ILI cases are among our volunteers, how many gastrointestinal syndromes, and so on and so forth. So far, we have reached a population of volunteers of about 40,000. It's quite steady over the year, as you can see from the second plot, and it has been quite faithful and quite trustful during the past 5 years. This guarantees a very nice cohort of individuals that provide information on a steady pace during the influenza season. So we have a very good way to know how many individuals are sick among our cohort of individuals. Despite the heterogeneity in participation, as you can see from the plot above in this slide, you can see that according to the country, the number of participants vary a lot. Of course, it's because of cultural factors, and we are studying what are really the determinants for this kind of participation. And also despite the fact that in some countries people are faithful from one season to the other, and in other countries participants participate for just one season and then they maybe don't come back, the kind of epidemiological signal that you can get from these platforms is quite robust. Of course, it's quite noisy, but it correlates well, as you can see from this picture, with the ILI incidence measured by the sentinel doctors' surveillance. And this is quite reassuring because even if the numbers of participants vary a lot from one country to the other, the signal that you get in terms of counting how many ILI cases circulate among the population are quite reliable. Of course, our cohort is not representative of the general population, but still this does not really bother us too much because we are really interested in knowing what's going on among individuals that are not observed by sentinel doctors. So even if our sample is not representative, the kind of information that we get is somehow complementary to the one that is caught by sentinel doctors. The kind of information that we can get from our volunteers is really, really detailed. We have nice information about distribution in age and gender in all the participating countries, and we can compare it to the one that is of the respective country in the general population. So we can see that usually we overrepresent a bit the male part and underrepresent a bit the female part. We overrepresent a bit the young adult age bracket, but again, this is not a problem because it is exactly the age bracket that usually is not seen by doctors. We have a not so bad percentage of elderly people participating, so this means that the population of volunteers becomes more and more familiar with this kind of technologies that don't prevent volunteers from participating to the study. We have information about socioeconomic status of the participants. We know their educational level, the average size of their families, the distribution of family composition. When it comes to influenza, and we will see it in a minute, knowing how many children are in your household is also quite important. We have information about their health, whether they have been vaccinated, if they have chronic conditions like asthma and diabetes, if they are smokers or not, and so on and so forth. And even information about their mobility, because we ask them about their postal code where they live and the postal code where they work. So we have a rough idea of the kind of mobility they experience in their everyday life. And all these ingredients can give us a very good idea of what are the risk factors for ILI. In this, I don't know if you can read it, but using data from almost all the countries for several years, we could show that being female, living with children, or being a child and having chronic conditions is a risk factor for influenza. While, for example, as you can see, taking public transportation is not actually a risk factor for influenza, which is a bit counterintuitive. And this is thanks to really the individual level of data and to the individual level of demographic indicators that we can gather from our users. And in the various countries, all sorts of activities have been carried out to enhance the study. For example, in the UK, flu survey the flu survey team has carried out a study in which participants were asked to perform self-swabbing, and this is done to somehow confirm how much influenza is actually circulating among the volunteers, for which we can observe only influenza-like illness. In France, they have studied pregnant women among their cohort of volunteers to study and mainly understand the attitude of pregnant women towards vaccination for flu. And in Italy, we have focused on another aspect. First of all, in Italy, we have deployed a mobile version of the platform, trying to leverage on the fact that Italy is one of the countries in Europe with the lowest penetration of internet through, let's say, desktop computers, but the penetration of mobile technologies is very high and it has been growing a lot in the past years. So by trying to really leverage on this kind of technology, we are trying to attract more and more participants. And by using the mobile version, let's say, we try to collect more data in relation to this study. What we did in the past 5 years was to try and use data from the platform in Italy to carry out forecasting of seasonal influenza based on the data that we collect through our volunteers. As you can see, the numbers are not really so high. In the past 5 years, we managed to have a growing number of registered users that correspond to a, let's say, steady number of active users. There are users that report steadily during the influenza season the kind of information that is interesting for us. Despite this, the number of symptom surveys grow. It means that the activity of active users become more and more intense from one year to the other. And this has allowed us to perform very nice work on forecasting seasonal influenza. Very briefly, we have built a baseline model that uses only reports from sentinel doctors and that usually forecasts influenza based on the reports from previous weeks during seasonal influenza. We can distinguish between nowcasting and forecasting if we make predictions only for the next week or for several weeks in advance. And then we built an integrated model in which we use the participatory surveillance data that I just talked to you about in combination with sentinel doctors' reports. And we have tried and understand how these integrated models that are based on sentinel doctor reports and participatory surveillance perform with respect to a baseline models based only on sentinel doctor's report. And the interesting thing is that even for a very, let's say, small sample, only 4,000 users and 1,000 of active users, like Italy, in which the participation is really not ideal, the kind of predictions that we get when we integrate participatory surveillance data and sentinel doctor's report is quite good. In these plots, we show the comparison between the baseline model and two different models in which we integrate only 1 week of participatory surveillance data or 4 weeks of participatory surveillance data, and studying also the nowcasting case or for several weeks ahead case. And we find that by several metrics, I won't go into details, but if you want to know more, I can tell you about, the 4 weeks ahead model performs better in all the, let's say, time horizons that I just mentioned. 0 so only the next week or 3 weeks in advance. And this is very important because it means that even for a very noisy cohort in which the epidemiological signal is really not ideal, the kind of predictions that I can get are really good. And this is thanks to the fact that data, even if they are sparse, they are so good, very high resolution in time and space, and very high specificity. We have published these findings, we will publish these findings in the proceedings of the computational health tracks of WWW 2017, upcoming in Australia in a couple of months. And also we have used this kind of data, so not only for Italy, but for all the other European countries that we have available, in integration with the global epidemic and mobility model that Alex just mentioned to carry out forecasting of seasonal influenza on a larger scale, possibly on a global scale, to have predictions for more countries. I won't go into the details of that, just to tell you that the results can be seen on a platform that is called fluoutlook.org, in which you can explore the results of this forecasting. Let me just also mention the fact that influenza has served as an example for the United States for once. And so they created, Harvard Medical School created a system called FluNearU that would mimic the same kind of data collection that InfluenzaNet is carrying out. And the same in Australia, a system called FluTracking.net. There are some additional work that can be done. Let me just mention the fact that we are now studying behavioral aspects through the information collected through the platforms, and just let me thank the people involved in InfluenzaNet and in the ISI and MOBS lab. Thank you.